Joining me now is Reitano, co-founder and CEO of Row. I do want to take a step back here, and like you said, you could break down the differences between the oral and the injectables, as well as the difference between Wegovy, which is a big name, and then Ozempic, which is a type 2 diabetes medication. Can you break all that down for us?
Happy to explain the differences between orals and injectables and Ozempic and Wegovy and some of these other drugs. It's a very long conversation, so I'll do my best to do it quickly. But Ozempic and Wegovy are both are different brand names for the exact same drug, which is semaglutide. And semaglutide is part of a class of drug called GLP-1s, which some people may have heard. GLP-1s, the class of drug, have been around for about 18 years, originally, as you mentioned, to treat type 2 diabetes. About 5 years ago, you saw Ozempic come on the market, which is FDA approved for type 2 diabetes, and that is, again, semaglutide. And it was patients saw, while it was originally approved for type 2 diabetes, patients who were using it, they saw patients lose weight on it really effectively. And so they then ran additional studies at different doses, showing that it could be used for patients who have overweight or have obesity. And there's a few different criteria, but the criteria for Wegovy, which is the FDA-approved version of semaglutide for weight loss, again, this is a lot to follow here. The label for Wegovy are patients who have a BMI of 27 with comorbidity or a BMI of 30 plus. And yes, there's a whole host of complications with BMI, but that is what has been used by insurance companies and the FDA in terms of on-label use for FDA-approved weight loss medications. Both Ozempic and Wegovy are once-a-week injectables. So they're subcutaneous injections, relatively painless for patients, and patients take them once a week. One of the challenges with injectables, in addition to some patients having fear over injecting themselves, is the fact that they are these large molecule drugs. They can be very expensive to produce, and they have a shorter shelf life. They need to be refrigerated. You need to in order to ship them, they have to be cold chain shipped. And so there are new oral medications that some are of the exact same active ingredients. So some are also semaglutide with a different brand name, but others are of the same GLP-1 class or GLP-1 and GIPs. You recently saw Eli Lilly announced what's referred to as triple G, which is another weekly injectable. So there's this new wave and this new class of drug with very similar either single action, dual action, or triple action mechanisms, all around the same goal of helping patients with their cardiometabolic health. And so you saw Ozempic approved about 5 years ago, you saw Wegovy approved about 2 years ago, and you're seeing a tremendous pipeline more recently, all in a similar area to help patients who have overweight or have obesity, as well as underlying comorbidities. And I'm happy to talk about some of the results that we're seeing, but at a very high level, you're seeing reductions in A1C, reductions in LDL, increases in HDL, improvements in quality of life. So while people are talking a lot about weight loss, and that has been the primary endpoint for a lot of these trials, we are seeing significant improvements in patients' underlying cardiometabolic health in a way that hasn't really ever been seen before. And so it's really an exciting space to be in. And I think we're at the very, very early stages of sort of a new era in medicine and the treatment of obesity as a disease.
And the psychological results must be astounding as well. But I'm a little curious here because obesity is not a new problem. As you said, I believe 43% of Americans are either overweight or obese. So why is there such a stigma around these types of drugs?
It's a great question. The biggest reason, and again, this is sort of one person's opinion, but the biggest reason that I think there's a stigma towards those who have overweight or have obesity is that it is falsely seen as a disease or a failure of self-discipline or a failure of willpower. So there aren't very many health conditions where when you look at someone who has that health condition, that the majority of people immediately make a snap judgment about that person. They make a judgment that they don't have as much self-discipline, or they don't diet and exercise, or they don't do the things that you need to live a healthy life. And I think what we've learned is that's largely not true. Similar to other chronic diseases, there are significant genetic components, significant environmental components, in addition to behavioral components. And the more that we learn about obesity, the more that we learn that it's a neurohormonal, both progressive and relapsing disease. And these medications are sort of case in point, they're proof of the fact that there are biological processes going on in someone's body that is far more outside their control than people had originally realized. And I think that that is hopefully what's going to break down this stigma. But people view it because they view that there is a solution, which is not true, that there is a solution for the majority of people that just requires a different set of behaviors. They judge those who are using treatment to see the level of success that they have. Now, if we replaced, what I think is really, really fascinating is whenever I think people potentially are exhibiting bias towards those who have obesity or have overweight, a really easy way for you to sort of realize or see if that's the case is to ask yourself if we would react the same way if we replace the word obesity with diabetes or heart disease, right? 80 to 90% of patients who have diabetes also have overweight and have obesity. And obesity, as we talked about before, is associated with 8 out of the 10 leading causes of death. And so there's a tremendous stigma against it. And these medications are so effective, and there's sort of a false perception of the solutions that are best used to treat it. And again, we can talk about the differences between treatment and prevention, because I think that's a whole nother category of discussion here. But I think that is largely the reason why there's historically been such a stigma around it. I think it's a largely misunderstood disease, a chronic disease, and that misunderstanding leads people to view those who struggle with the disease very differently and unfairly.
Something that's really striking me in our conversation right now is you are continuing to say someone has overweight, someone has obesity. Can you explain why your language right now is so important?
I think that I'm glad you noticed that. I think at this point it's very natural for us and our team. But the primary reason is that we don't want to define people by the disease that they struggle with, right? So I think that there's been a large and important shift in medicine when speaking about patients who have certain illnesses to transition from someone is a diabetic to someone has diabetes, right? Someone should not be defined by their illness or their challenge or their health state in any way. And so I think, again, that's very, very important here, especially given the disproportionate stigma attached to those who have overweight or have obesity. And so we try to be very, very intentional with our language. And I'm glad you noticed.
I noticed right away.